Okay. I hope this time my microphone will not stop working. We finished last class with a conversation about cardiac output. Now, I'm going to give you the quiz today, which discusses a lot of it. And so basically, you have to be very comfortable with the questions such as, if we increase end-diastolic volume, how does it affect cardiac output? If we increase extracellular potassium, how does it affect contractility? Okay? Or if we stimulate heart with epinephrine, how does it affect heart rate? How does it affect contractility? What's going to be the result for cardiac output? What's going to happen to end-diastolic volume and systolic volume? Does that make sense? So there are a lot of questions like that on this quiz. But it's just practice it, okay? You can, like, if I have a question on the quiz that asks, what's going to happen to cardiac contractility if we increase calcium in the extracellular fluid? You say, okay, increased calcium will lead to this. What about decreased calcium? Does that make sense? Got it? Okay. So, basically what we figured out is that if you make end-diastolic volume higher by either increasing venous return or making diastole last longer, right? Slowing the heart rate, then stroke volume will increase. If you make end systolic volume smaller by squeezing more blood with each pump and basically via increased contractility, your stroke volume will increase and so will cardiac output. If your patient has high blood pressure, systemic blood pressure, then afterload will be high and stroke volume and systolic volume, will be high. Stroke volume will go down because, you cannot squeeze as much. You work against the resistance and your cardiac output will decline. Now, strictly speaking, your cardiac output cannot decline at rest. You cannot, like, if you lying on the bed, your cardiac output, it must remain the same. Otherwise, you'll die. Okay? So, if your stroke volume increases, your heart rate will go down. If your heart rate will go up, probably because of the decrease in stroke volume. Does that make sense? Because cardiac output at rest will be basically constant. Does that make sense? We're clear about it. Let's talk about pathologies. Mainly, congestive heart failure. So, heart is what we're talking about. Failure is not an option. And congestive means that blood accumulates in one of two circuits, pulmonary or systemic. We already mentioned that, right? So, your left side can fail or your right side can fail. So if left side fails, then blood pumping in which circuit becomes inadequate? If left side doesn't work properly. Systemic circuit doesn't receive enough blood. What happens to the blood that it doesn't receive? That little tiny difference. Where does it go? Where does it stay? In the pulmonary circuit. What are we going to observe? Pulmonary edema and another very fascinating pathological sign, so-called heart failure cells. If you think about this, in pulmonary edema, not only plasma but also red blood cells will end up in the lungs. In your alveoli, there are macrophages called alveolar macrophages that consume whatever gets in the alveoli, whatever is not supposed to be there. Does that make sense? So they will start consuming red blood cells. And they will be filled with iron and hemosiderin. If you would look at them under the microscope, they're like blackish because of the iron that they consume. That's very characteristic pathological feature of left side failure. Right side failure leads to peripheral congestion. So in this case, edema is going to be observed in organs, in peripheral tissues, not inside of the lungs, but in the peripheral tissues. Now, think about this. Which organs receive a lot of blood? Liver, spleen, kidneys. Liver, because it's your metabolic factory. Blood has to go through it all the time. Kidneys, because they filter. That's a different story because, blood goes through kidneys pretty quick. And spleen, because it gets rid of the old red and white blood cells. So they receive a lot of blood. And if you have a systemic congestion, peripheral congestion, then the patient will be present with hepatomegaly, enlarged liver, and splenomegaly, enlarged spleen. Does that make sense? Cardiac cirrhosis and sclerosis due to the pooling of the heart, increased pressure in the coronary arteries, inflammation due to that injury, that's going to lead to cirrhosis. Effusions, peritoneal, pleural, and pericardial infusions. The reason for it, especially pleural, is a great illustration for it in my opinion, because if you think about it, your lungs, they receive blood actually from two circuits. Does that make sense? Pulmonary circuit, pumps the blood that needs to be oxygenated. But lungs have actual tissue that needs oxygen supply. That's going to be part of a systemic circuit. And if you have systemic congestion, then that extra fluid will get into the pleural cavity. Okay? And hypertension. Pulmonary hypertension and portal hypertension, which is really hard to treat. Okay? Does that make sense? Now, what can lead to the congestive heart failure? It's basically failure of the cardiac muscle to pump the blood. Reasons: first and foremost, coronary atherosclerosis. You have coronary arteries which supply blood to the myocardium. If these arteries are obstructed, blood supply to the myocardium goes down, and myocardium can't pump really. Does that make sense? High blood pressure. Work against the huge afterload. That's basically it. Now, high blood pressure itself may lead to cardiomyopathy. On this great picture, you can see two conditions. This is it's a left ventricular cardiomyopathy, but I just blank on the name. It's not dilated cardiomyopathy. Pretty much it's cardiac hyperplasia, can we say? You can see how thick the walls are. Okay, so the muscle is huge, but the volume of a chamber decreases. On the right, this is an example of dilated cardiomyopathy. Can you see how big the ventricles are? But the thing is, it's just harder to pump when you have a larger volume with the same size of the muscle. That's it. They have to work against the bigger volume of the blood that's in the chamber, and they have to go a longer distance. Okay. Now, that dilated cardiomyopathy and cardiac hypertrophy, pathological cardiac hypertrophy, are often caused by, intrinsically elevated blood pressure. And of course, myocarditis, inflammation of the cardiac muscle, that is often caused by infectious agents. The most common cause of viral myocarditis, as I mentioned, is Coxsackie virus. The most common cause of bacterial myocarditis, well, it's hard to pin down to one, but that would be probably Mycobacterium tuberculosis. Okay. Now, treatments are not really, you're not curing, you're treating. Okay, so remove fluids, you stimulate heart to increase contractility, so you increase calcium, or you give people digitalis, or assisting devices. Stem cell therapy, and it's not available yet. Hopefully at some point it will be. Right? Just to, replace the damaged myocardium, it would be lovely. It would probably live like 150 years, which would be a nightmare for everybody else. Now, so one pathology, now think about this. What are the pathologies of the heart? Basically, one is when valves are incompetent due to the endocarditis, right? So heart has to put extra effort to pump the blood because of the regurgitation. This may lead to extra effort from the myocardial side, which means either dilated cardiomyopathy or just cardiac hypertrophy, right? So that's myocardial problem. In case of cardiac tamponade, if you have a pericardial effusion, if you have accumulation of fluid in pericardial cavity, then heart has harder time to pump. It will also ultimately lead to the myocardial failure. But those conditions, or you have coronary artery disease, CAD, okay, coronary atherosclerosis, when cardiac tissue doesn't receive enough blood, it may lead to either, hypoxia and damage to the heart, or it may lead to full-blown myocardial infarction, that also will ultimately take the toll on the myocardium. So if you would if we would try to sum up all the conditions, all the conditions of the heart disease that happen in adults, what happens in the end? Which layer of the heart fails ultimately? The muscle. The muscle fails, right? It all comes down to the muscle failure. Now, another sort of a huge category of cardiac pathologies are congenital heart abnormalities. So when heart develops from the tubes. Initially, you have basically two chambers, okay? You have venous sinus, you have atrium, you have ventricle, and then you have bulbous cordis. So actually, that's very early. This heart looks more like the heart that we can find in fish, I think. Yeah, two chambers. Yes, that's fish. And then we eventually develop 4 full-blown chambers. Basically, by the day 35, fetus already has the heart that's pretty similar to the adult heart. So a ventricle, future ventricles, okay? You have future atria that will be connected by the foramen ovale, and you have aorta and pulmonary trunk. And you can see here that at this point, ventricle is not, ventricle just one. It is not separated by the septum yet, okay? Atria not separated by the septa yet. You still have foramen ovale. Moreover, aorta and pulmonary trunk are connected by the structure called ductus arteriosus. And the huge classes of congenital pathologies stem from the failure to establish proper separation of atria from atria, atrium from atrium, ventricle from ventricle, or aorta from pulmonary trunk. So, left to right side shunts will include atrial septal defect, ventricular septal defect, and patent ductus arteriosus. So if you would look at this, first of all, which side of the heart produces higher pressure, ultimately? Left. So if you have a shunt from left, if you have a shunt between the left ventricle and the right ventricle, obviously blood will go from left to right. So you lose some of the oxygenated blood that goes, instead of going into the systemic circle, ends up in the pulmonary, right? So one of the most common symptoms, cyanosis, okay? Which means insufficient supply of oxygen to the tissues, specifically oxygen. So blood goes to the tissues, but it doesn't bring enough oxygen. Pulmonary hypertension, because think about this, that extra blood that leaves left side and ends up on the right, where does it go? It goes into the pulmonary circuit. It leads to the pulmonary hypertension. And I will say a few words about pulmonary hypertension in a second. Eventually it may lead to the heart failure because of muscle dysfunction, formation of emboli, and dilation or hypertrophy. Now, I told you I'm going to say a few words about hypertension. Do you know people with regular hypertension? Just hypertension. You probably do. My mom has hypertension. Okay. Hypertension, as well as diabetes or HIV, seriously, are chronic diseases which are considered to be chronic manageable diseases by World Health Organization. Which means, can you die from hypertension? Yes, absolutely. But if you take drugs, you're going to be fine. Can you die of HIV? Yes, absolutely. But if you take drugs, you're going to be fine. Okay? Now, pulmonary hypertension. There's a condition called idiopathic pulmonary hypertension. What does the word idiopathic mean? Huh? Unknown what? You're unknown origin. Very good. So, idiopathic pulmonary hypertension is a terrible disease. First of all, nobody knows what causes it. And second, there is no treatment. So basically, people with idiopathic pulmonary hypertension, they develop heart failure in about a span of 2 years and die, which is quite terrible outcome. Okay, there are treatments, but they're not extremely effective. Okay. Now, shunts, obstructions, different types of shunts. So this is a very, first of all, septal defects are very common. Moreover, healthy kids may have small septal defects. What I mean by that? If you come to a pediatrician, you bring your child to a pediatrician, and your child is 1 year old, and the pediatrician listens to the heart, pediatrician may say you have some unusual murmurs. Maybe there is an incomplete closure of the interventricular septum. And what they're going to do? They're going to wait. Because in many kids, foramen ovale or interventricular septum, they close completely, 100% later in life. Does that make sense? It doesn't mean Kid's going to develop heart failure. It doesn't mean they're going to die of, I don't know, they're going to be cyanotic. No. They may be minor, very minor opening. That makes sense. Now, most frequent, of course, are septal defects that we just discussed. Patent ductus arteriosus is pretty frequent. Tetralogy of Fallot is not as frequent, and in this case, the poor child has several problems. First, as a shunt between right and left ventricle. It has pulmonary stenosis. So stenosis is the narrowing of the blood vessel. Does that make sense? And right ventricular hypertrophy. Now this is fascinating. Think about this. Pulmonary trunk is stenosed, which means right ventricle has to put a lot of effort to pump the blood to the lungs. As the result of it, right ventricular wall becomes thicker and stronger. And in this case, blood will be forced from right ventricle to the left ventricle. Okay? Which means you now have deoxygenated blood that gets in the systemic circuit. So again, cyanosis. And probably the most fascinating, I understand, it's really horrible to say this, but for me it's just absolutely fascinating. The mistake that happens during the development is transposition of great arteries. Look at this. And this is actually, that's the actual heart with transposed great arteries. So this is right ventricle, right? Correct? This is left ventricle. Now, left ventricle is supposed to be connected to aorta, but here, in this image, it is connected to pulmonary trunk. Right ventricle is supposed to be connected to pulmonary trunk, but instead, it's connected to aorta. So what essentially happens is that systemic circuit and pulmonary circuit are completely separated. Absolutely separated. Okay? So, that is the condition that, of course, is incompatible with life outside of the womb. So this condition, as far as I know, there are techniques that allow surgeons to do a heart surgery on a baby while baby is in the womb, which is crazy, in my opinion, just absolutely insane. Okay? Heart surgeries fixing congenital heart defects like septal defects and tetralogy of Fallot, it's doable. As far as I know, those surgeries become almost routine. Okay? Now, obstruction. So that's shunts. Obstructions. Aortic coarctation. So this is the coarctation with connection of the aorta and pulmonary trunk with the patent ductus arteriosus. So here's the connection. And this is the coarctation without the connection. In case of connection, coarctation with patent ductus arteriosus, cyanosis, again, because the distribution of oxygenated versus non-oxygenated blood is not normal. Does that make sense? Another, high blood pressure in the upper body and low blood pressure in the lower extremities. Why? What is coarced? Look at this. So this is a narrowing in the aorta. So you have normal pipe, and then it narrows down, and then it's wide open again. So when blood flows through the aorta, what's going to happen to the blood flow through the coarctation? It's going to slow down. The amount of blood, it will be hard to push. Okay? So the amount of blood that will reach the thoracic and then abdominal aorta and then ultimately, iliac arteries and lower limbs, the amount of blood will go down. But that extra blood that will not reach the bottom will go up through the brachiocephalic trunk, carotid and subclavian arteries, and it will reach head and arms. Well, there is a regulation of blood pressure in the head. Blood flow through the brain is regulated pretty tightly, but upper limbs, that's free game, pretty much. Does that make sense? Now, stenosis or atresia, just to introduce. So when we say something is stenosed, it means that the lumen of the blood vessel is decreased. Stenosis can be a result of congenital abnormality in adults. Stenosis is often a result of the inflammation in the blood vessel. It can be atherosclerosis, it can be damage to the wall, many reasons. Atresia is almost lack of aorta, okay? Hypoplasia, when it's not properly formed. Does that make sense? So, what I want you to know about pathologies. Main symptoms. So, I'm not going to ask you some crazy stuff, but let's say if we talk about abnormalities like shunts, whether it's the septal defects or patent ductus arteriosus, know that the main symptom is cyanosis. Why? Because oxygenated and deoxygenated blood are mixed. That makes sense. Understand what happens in the tetralogy of Fallot. So you have stenosis of pulmonary trunk, you have septal defect, and you have hypertrophy of the right ventricle because of the pulmonary trunk stenosis. Okay. Understand that in the transposition of the great arteries, you have complete Why is it incompatible with life? Because you have absolute separation of two circuits. Does that make sense? And in terms of the coarctation, just know what it is. That it's narrowing down the lumen of aorta. Does that make sense? Now, what happens? That's a lot. Now, few things that I want to highlight about heart in older people. What happens to your heart when you become older and older? Not everything that I'm gonna ask in the exam. What happens with the myocardium? It becomes thicker, which makes sense. Why does it become thicker? Give me your ideas about it. Mm-hmm.
As people get older, their average blood pressure goes up, so they need larger myocardium.
Exactly. Usually, blood pressure in elderly normally goes up, and myocardium will respond by increasing its thickness because it has to work against the larger, higher afterload. A little digression on the side. Dietary treatment for hypertension. Whole milk. There was a huge dietary study that showed very good correlation between the consumption of whole milk, not 2%, not skim, but whole milk, and actually decreased blood pressure. Aorta. What I want to specifically highlight. Plaques and deposits. Okay. So as we get older, the atherosclerotic plaques that are often called atheroma, they will accumulate in basically all blood vessels. Okay? Chambers, left ventricle will become a little smaller because of increased thickness of the muscle. Does that make sense? What you just said, Eric? When we become older, we work against the higher blood pressure. As we work against the higher blood pressure, muscle becomes thicker. As muscle becomes thicker, there is less space for the blood. So cardiac output actually decreases. Okay? Valves. Calcified. So what do you think can calcification of valves lead to? Regurgitation. Yes. Okay. Coronary arteries. These two. I want you to focus on those because you're going to see a lot of coronary atherosclerosis. And coronary atherosclerosis means lower blood supply to the heart muscle. Again, it turns out that indeed some studies suggest marathon runners have higher rate of coronary atherosclerosis. I'm not really concerned about it because I'm living by Jack Nicholson's words. Have you seen Witches of Eastwick movie? Well, I've seen it a long time ago, but if you haven't seen this movie, I strongly suggest it's wonderful. It's a gorgeous movie, and one of the great phrases when one of the characters asks Jack Nicholson, does he exercise? He responds with, I want to die sick, not healthy. So, we conclude the heart theme and we move on to the blood vessels. So we're going to talk about the anatomy of the blood vessels and the regulation of blood pressure. So a few basic things. First of all, arteries, blood away. Veins, blood to the heart. Capillaries are in between. As always in anatomy and physiology, structure is immediately linked to function. Okay, and you will see it. Arteries are high pressure vessels. Do I make sense? Whether they big arteries, small arteries, but there's a lot of pressure. And for now, we're going to be talking only about systemic circuit. We're not going to touch pulmonary circuit. Okay, so from now on, so when I say arteries carry oxygenated blood, I refer in our discussion to the systemic circuit. Okay, we're good? We're not mentioning pulmonary anymore. So arteries and veins have three major layers, three tunics in the wall. So tunica intima is the innermost layer, which basically, the major component of tunica intima is endothelium. Okay? When somebody says, tunica intima, you have to think endothelium is the key player here. Second layer is tunica media, which is, when somebody says tunica media, that's immediately should be, oh, smooth muscle. And the third layer is tunica externa, which is connective tissue collagen. So something that holds, protects the entire blood vessel. Does that make sense? There are other structures, don't focus on those. Now, few words about specifics. First of all, endothelium, the layer of the cells that line the inner surface of the blood vessels. Let me actually grab those. Okay, that's lovely. So these cells here, which type of tissue do they belong to? Endothelial cells.
Okay. Annalise? I saw you saying that. Yes.
That's epithelium, right? Because it separates lumen and other stuff. Why? What type of epithelium then? How many layers? So again? Squamous, how many layers? How many layers here? The orange. Oh, tell everybody, how many layers? No, just look at the orange line. How many layers? Just one layer. So one layer, and they squamous, so it's simple squamous. But we're not calling that simple squamous. For some reason, we're calling them endothelial cells. Because they're special. They really are. I'm not kidding. Unlike other examples of simple squamous epithelium, like, I don't know, simple squamous epithelium in the lungs, for instance, okay? These endothelial cells, they control dilation and constriction of blood vessels to a large extent, okay? They control hemostasis, which is coagulation of the blood. They interact with white blood cells that can be found in the blood and control the transport of white blood cells across the wall of the blood vessel. They play enormous roles in the function of cardiovascular system. So that's why they receive that special name, endothelial cells. Now, some blood vessels have structures that are called Vasa vasorum. So they can be seen here. You see those red and blue dots? What do you think of those? Vasa vasorum can be found in tunica externa. The word vasa, what does it refer to? Huh? Say it? Vessels. So vasa vasorum are vessels in the vessels. Every cell in the human body is located no farther than 50 micrometers away from a blood vessel. Because otherwise, nutrients and respiratory gases wouldn't be able to reach that cell. If you would take, well, that's an example probably of an elephant, I suppose. But if you would take even human aorta, it is pretty thick. Okay? Mouse aorta has fairly measurable thickness. You can see how thick it is. Okay? Human aorta is even thicker. It's so thick that it cannot receive oxygen. So you have aorta, right? You have the wall of artery, aorta, whatever it is. And it is so thick that cells in the middle, or moreover cells in the periphery, cannot receive oxygen or nutrients from the blood that flows through the vessel. Does it make sense? So there's separate circulation through the wall of the blood vessel to provide that wall with oxygen and nutrients. Does that make sense? Do you understand what Vasa vasorum? Now, importance of tunica intima and tunica media. Thickening. Imagine there is some kind of a damage to endothelium. Injury immediately leads to what? Inflammation. And inflammation leads to the repair. And repair may lead to overgrowth of either endothelial or smooth muscle cells. Most frequently, in inflammatory responses in the vessels, thickening of the vessel walls come from the tunica media. Does that make sense? Now, if you think about this, if this is the normal vessel, then medial thickening, how is it going to change the lumen? Huh? It's going to be narrower. That's right. So that's medial thickening. How do we fix it? Huh? How do we fix stent? And what's going to happen after 3 years? So 5 years with a stent? Huh? You need a new one. Why? Say again? Speak louder. I can hear you. Exactly. Smooth muscle cells, for them, stent is still an injury. They start to grow over the stent, so you need a new one to spread them out. And it's a treatment, not a cure. Okay? So, if you would compare, arteries and veins, they both have same layers. There's going to be different amount of smooth muscle. That's that, yeah. And endothelium is going to be slightly different. Endothelium in veins is going to be different from endothelium in arteries. There is another treatment while we are at the topic, which is making a shunt. When people have, say, coronary heart disease, surgeons can take fragment of a blood vessel, take the damaged fragment with a lot of atherosclerotic plaques, for instance, or fragment with aneurysm, and put the substitute fragment in place. And you can do it in the same person. So you take a piece of blood vessel from some part in the body, and you put it, say, in another part of the body. What is the source vessel? Does anyone know? So when they do shunt in the artery, what is the source vessel? Is that an artery or a vein? It's a vein. Exactly. It's vein. Usually it's one of the leg veins, deep veins in the leg. The reason for it, because veins are very branched, pressure is lower, you can kind of, take it out, it's not going to affect the circulation that much. Now, if you think about it, you take fragment of a vein with a pretty narrow walls, okay, it's vein, and you put this instead of an artery. So it's like, you want to replace a fender on a car. So you're good at origami. You make it out of cardboard and stick it on the car. And it looks like a fender, but it's not going to function as well, right? The most fascinating thing is that shunt that is made out of vein, in a matter of weeks, becomes an artery. So the wall of a shunt is completely remodeled. Eventually it is indistinguishable from artery, and we still don't know the exact mechanisms, but probably it's mechanical because of the pressure forces. And importantly, we'll get there, but if you think about the flow, as we discussed, arterial flow is fast and high pressure, venular flow is slow and low pressure. Probably those mechanical differences, they change the nature. Oh, by the way, on the micrographs, when you look at the micrograph of any tissue, how you tell apart the vein from the artery. Cross-section of the vein from cross-section of the artery. Hint, one of them will be completely collapsed. Which one? No, artery. Because a lot of muscles, very thick walls, you will see practically no lumen in the artery. Vein, you will see great free lumen. Okay? Now, I've waited to talk about capillaries because they honestly boring, really. A lot of things happen there, of course. Capillaries are extremely thin-walled. You can see that the only thing that they have, well, two things. They have endothelial cells and they have basement membrane. They have no muscles, no thick connective tissue, collagen fibers, all that crap, okay? Basement membrane and endothelial cells. Does that make sense? Why they are so thin? Gas and nutrient exchange, yes. What is the size? I'm not asking numbers, God forbid. So size of the capillary. It should be no smaller than the size of the smallest blood cell, yeah. And I do not have video of the blood cells squeezing through the capillary, but I can guarantee you they're squeezing. It's impressively slow. It's like somebody tries to pull itself through the tube that is really narrow. They're like barely pushing through in a completely healthy circulation. So it's really slow. Now, arteries. There are three types of arteries: elastic, muscular, and arterioles. Elastic are conducting arteries. Largest. What is the largest elastic artery? Aorta. The biggest one. Okay. That's okay. So they have low resistance. If you think about it, the tube is great. Okay. The opening is great. The lumen is enormous. So blood flows very fast, freely. Pressure is usually large, but they do not show a lot of size changes, okay? And they will absorb changes in the pressure. Think about what's going on in the heart. Heart squeezes. At the end of systole, what happens to the pressure in, like, aorta? It goes up, right? And during the diastole, pressure goes down. Large elastic arteries, they buffer these pressure changes. Okay? Does that make sense? So when blood reaches smaller blood vessels, the pressure is basically flat. Okay? There are no these huge changes. Does that make sense? Also, thankfully, they do not have vasomotor responses. So what is vasomotor response? Vaso means vessel. Motor means muscle. Vasomotor response is the muscle contraction in the vessel wall. Sounds totally weird. What is muscle contraction or relaxation in the vessel wall? What does it project to? How do we call this? Dilation or constriction, right? And it's great that those arteries do not have those responses. Because if your aorta constricts, you're dead. Okay? And so they shouldn't. You know? Like, carotid artery constricts and you faint. Because no blood supply to the brain. Does it make sense? Muscular arteries. As you can guess, there's a lot of smooth muscle, okay? So they do constrict and they do dilate active vasomotor responses. These will deliver blood to the organs. Okay, they're smaller. They may actually deliver blood to a specific tissue, part of the organ. Okay, so they regulate the blood flow. Does it make sense? And finally, arterioles. My favorite blood vessels. Arteriole means small artery. Very active in vasomotor responses. They immediately regulate blood flow to, say, a certain patch of tissue. Does that make sense? They will almost constantly dilate and constrict, therefore providing a specific fragment of an organ or a tissue with oxygen, nutrients, and getting CO2 out. They don't have a lot of smooth muscle though. I'm absolutely thrilled and excited to talk about this because I was looking at those damn blood vessels for 5 years of my life under the microscope. And I have some videos. I'll show you some videos. Venules, often called post-capillary venules. Smallest vessels, okay? Porous and fluid. White blood cells, plasma can cross venular walls. Okay? Oh, damn it. While I'm going to be talking, I will try to find those videos and show it to you. Now, in smaller postcapillary venules, you have practically no smooth muscles. Then smooth muscles will start to appear and they can be very patchy. Does that make sense? So, can venules constrict, sorry. Bigger ones, I saw it with these own eyes in the mouse. Yes, they can. But say if you have the venule with a diameter of 50 micrometers, it will constrict to say 40. Now, constriction of an artery can be much more significant. Let me try this. It's Google Drive. Okay. I think it's here. Jesus Christ. Wait a minute. Vasa. Yeah, that's venules. Smooth muscle cells. I'm sorry. Smooth muscle cells. Okay. This should be some. Where's this? Yes. I think I found it. Yeah, awesome. Okay, screw that. No, I don't want to download anything. Now, I think this whole thing is kind of cyclical. Hey. Duplicate. that should work. Okay. Now let me start over. So this is the arteriole in the mouse. I would guess the size is about 20 micrometers. I don't know if you can see how fast it flows, but it flows extremely fast. And here we apply acetylcholine, and that relaxes smooth muscles. Can you see the size change? That's pretty dramatic. Now this, it probably changed the size, I don't know, twice. Well, I mean, twofold. In my experience, in some animals, I saw the change in terms of the diameter up to 150%. So they could go from, say, 30 to 75 micrometers. But usually it means that this arteriole is pre-constricted. Does that make sense? So it's not in the baseline. It's kind of a little constricted. And then the same vessel, if you put epinephrine on it, it will completely collapse. Just completely. So the vasomotor responses are incredible in terms of the range. Veins, yeah, good luck with that. However, what you're going to see in veins is, I'm going to play. Oh yeah, okay. So this is a typical vein in a mouse. And, well, it's not that typical. Well, you can't, first of all, you can't see blood flowing, okay? So you can see blood flowing, and those little circles that run on the sides, those are white blood cells. You saw none of those white blood cells in the artery. In the vein, that's actually a very clean vein. It's the good mouse, no inflammation, it's not fat mouse, no high cholesterol, very healthy animal. Okay? So you're not going to see any of the cells in the artery. Why? Arteries are vessels with high pressure and high flow velocity. Those cells, they just cannot stick. They try to grab, but it's impossible. They cannot stick to endothelium, those white blood cells. They will be just washed away. In veins, oh yeah, that happens all the time. And moreover, those white blood cells, they can stop and they can travel across the wall of a venule. Okay? As veins become bigger, okay, they have very thin layer of smooth muscles, so weak vasomotor response, and the main, they have less smooth muscles, weak vasomotor response, and the main function of veins is to be capacitance vessels. So blood, if you think about it, blood flows through the systemic circuit all the time. It moves, it never, stands, never calm. But it is not equally distributed between all blood vessels. In fact, arteries and arterioles carry on only about 15%, pulmonary circulation 12%, capillaries just 5%, heart 8%, and veins and venules 60%. Veins represent the pool of blood in your body. Does that make sense? Okay? We good? Special kind of veins, the sinuses. Venous sinuses can be found in the cerebral circulation. They drain the blood from the brain to the jugular vein. Okay. So, resistance, very low. Blood pressure in veins, very low. They have valves. So in this model, you can see venous valves right here. Blood would go up, okay? And let's say these are enlarged deep veins of the leg, like small saphenous vein, for instance, or posterior tibial. Blood would go from here to here against the gravity. Gravity will pull blood down, but those valves will prevent the backflow. Okay, does that make sense? Capillaries, as I mentioned, smallest blood vessels. In addition to endothelial cells that are shown here and basement membranes, some capillaries have special cells called pericytes that provide sort of patchy surrounding, okay, and control permeability of capillaries. Capillaries are very permeable. You cannot find capillaries in the cartilage, in any type of epithelium, because epithelium is not vascularized, in the lens and in the cornea, which makes perfect sense. Those vessels are exchange vessels. Okay? We're good? Now, there are three major types of capillaries. Continuous, least permeable. If you would look at the anatomical picture, okay, you see cells are connected by the tight junctions, okay? Basement membrane is thick and solid. There are few clefts, intercellular clefts, that are pretty narrow, and the transport of things from the capillary to the tissues happens mostly via pinocytic vesicles, the vesicles that carry stuff from the blood to the tissues and back, and a little bit by the clefts. You're going to find that in structures that, where you do not have a lot of very intensive exchange, or where the transport between the blood and the tissue have to be controlled. So that would be muscle, that would be skin, and of course, brain. And then, more permeable type of capillaries is fenestrated. Okay? Intestines, endocrine glands, and kidneys. Now, intestines, what happens there? Nutrient exchange, a lot of it. Okay? So, that requires increased permeability of the capillary. Endocrine glands. Hormone production. Again, requires increased permeability of the capillary. Kidneys. Kidneys are very interesting because you have to balance two things. What do? Kidneys. They filter. Now, your filter should be permeable, but along with permeability, it should be more or less, strong mechanically, because if it filters that much blood at decent pressure, it should be damaged by this pressure. So fenestrated is sort of an ideal balance between permeability and mechanical quote-unquote resilience. In fenestrated capillaries, you start seeing openings that are surprisingly originally called fenestrations. Those openings allow transport. Anyone studied Latin languages like Roman, Italian. Fenestra, French, window. The word fenestration refers to the capital punishment when the person is thrown out of the window. So fenestrations are openings that establish additional pathway for the transport, clefts, and pneumatic vesicles, of course. Okay. And finally, the most permeable, sinusoid capillaries. You've already encountered them when we talked about liver. They can be found in the bone marrow as well. What kind of exchange happens in the bone marrow? What does bone marrow do? What does it make? What does it make? Huh? Blood. Not just blood. It makes blood cells. Because protein components are made by liver. Also sinusoids, a lot of protein transport. Cellular components made in the bone marrow. So you have to transport the entire cells. You need really permeable capillaries. Spleen. What happens in spleen? What do you need? Okay. Do you need spleen? You better have it, but if it's gone, it's no big deal. Utilization of blood cells, old blood cells, and some pretty good immune functions, T and B cell responses. So you need a lot of exchange too. And adrenal medulla. You have a lot of exchange between the blood, epinephrine, and norepinephrine producing neuroendocrine cells in the adrenal medulla. Right? Structurally, these capillaries have huge fenestrations, very sparse membrane, massive intercellular clefts. But they are also very easy to damage. Does that make sense? So basically, they are the leakiest, but it's kind of their function. Does that make sense? What you need to know about these three types: leakiness and where you can find them. So you're going to find sinusoid capillaries in brain, muscle, kidney, liver. So liver. Was I clear? Good. Capillary bed. Capillary bed is the set of capillaries that is located between a particular arteriole and particular venule. So, if you would look at basically any tissue in the human body, there will be a lot of arterioles and a lot of venules and a lot of capillary beds. Now, if you would look at the capillary bed in the muscle, skeletal muscle, and you would look at 10 capillary beds, in terms of the structure, function, permeability, are they going to be similar in the muscle? Yes, they are. If you would compare capillary bed in muscle and the kidney, are they going to be different? Of course, kidney is fenestrated, muscle is continuous. Now, a little bit trickier question. What if you would compare capillary beds in the liver and in the bone marrow? They're both sinusoid, but are they going to be different? Yes. Basically, in physiology of circulation, it's now accepted that capillary beds in each organ are pretty unique. So when you study, how we study, first of all, why microcirculation? Why it's so important? Well, ask, 10 members of Microcirculatory Society, there is a microcirculatory society and I was a member of it for 2 years, ask them which vessels belong to microcirculation and which vessels don't, they will give you 10 different answers. Kind of consensus, less than 100 micrometers in diameter. Okay? When we studied our mice, for our purposes, we used specifically vessels with a diameter from 20 to 40. A body of mine, like I was like in the middle of a table, I had my microscope. To the left there was my buddy's microscope, so his working size was 20 to 50. It's rather arbitrary. But what is known is that microvessels represent about 95% of all surface in the human blood vessel system. When I say surface, I refer to this. That makes sense? So if you look at those models, that's less than 5%. Okay? What this microcirculatory surface is comparable to, very, like, approximately, it's the size of a football field. So you can imagine how much exchange happens there. Wanted to say something very, very smart about surface and I completely forgot. Something like really cool, some other factoid. Well, when it'll pop back, I will tell you. Anyway, these capillary beds. Oh well, yeah. First signs of disease appear in microvessels before signs appear in large vasculature. What does that mean? What does that statement mean? Say you have a person that is otherwise healthy, but you want to establish if this person is at risk for cardiovascular disease. You can do functional measurements of the microvascular function. Does that make sense? That sounds terrible, I know. Basically, if those microvessels constrict and dilate properly. And if they do not, it tells you that this particular person is in the process of developing cardiovascular disease. This person's arteries, veins, large vessels may look absolutely pristine, okay? But they aren't as good as they used to be anymore. The blood flow through the capillary bed can be described as terminal arteriole, which enters mid-arteriole, which then delivers blood through the thoroughfare channel to the postcapillary venule. Now, so this is called a vascular shunt, mid-arteriole plus thoroughfare channel. Okay, why is it called a vascular shunt? How can you regulate blood flow through the capillaries? At the beginning of each capillary, there is a sphincter. Those capillary sphincters can open and close, and when they close, there is no blood flow through the entire bed. And the only way blood can reach from the terminal arteriole to the postcapillary venule is via vascular shunt. Does that make sense? Say if the tissue becomes hypoxic, it immediately needs oxygen, right? So that hypoxia, accumulation of CO2, for instance, in the tissue, will open sphincters and blood will enter the capillaries. So by the means of capillary sphincters, the capillary bed can regulate blood flow through the tissues at the very, very low, sort of elementary microscopic level. Does that make sense? Basically, vascular shunt is the example of anastomosis. Right? So anastomosis, in this case, it's the arteriovenular anastomosis. Anastomosis can be arterial, between arteries, venular, between veins. Veins anastomose a lot, much more frequently than arteries. Now not today, we're gonna talk about how blood flow through the tissue is regulated, mainly by hormones, chemicals, and a little bit by nerves. And now I recalled what I wanted to tell you about microcirculation. Have you ever seen the exhibition, something like Human Body or Body Revealed? So what they do, they take corpses, and fresh corpses, and they fill them with a special polymer. The guy that invented that technique is now a millionaire. And they can preserve a body forever, and it's kind of solid. So they can put a corpse in like running position, or they can specifically fill up blood vessels and destroy everything else, or they plastify the bodies. So if you ever see some like human body or something like that, body something exhibition, go there. It's the money well spent. For me, the most impressive thing was actually blood vessels. What they've done, they plasticized all blood vessels and then treated with some chemicals that removed the rest of the flesh. Bones, skin, muscles, everything, leaving only blood vessels. And when you look at it, especially from the distance, it looks like nothing was gone. There are so many of them that they completely occupy the space of a person, which is absolutely insane. So